All right, dear doctors. Good evening, all. I hope I'm audible and visible. Can somebody please let me know in the chat window if I'm audible, visible? Then I'll be able to start. So there is some lag actually. It's good that I can now directly check if I'm audible, visible. I think everything is fine. Good evening, Dr. Hemanji. Good evening, Dr. Hemanji. Okay. So without wasting any time, so we have got 2 hours with us, right? So we'll discuss radio ortho and we'll discuss couple of questions also. Mixed session, Hindi and English both, and I'll definitely share the PDF immediately after the session. Right. Okay. Dr. Ritesh ji, wow. Good evening ji, good evening ji. Wow. Dr. Lafi Reddy. खतरनाक नाम सबके. Okay, so without wasting any time, let's quickly start. Right, so these images, they show you rickets. Fine. For example, you see the first image here. What it's showing you, it is showing you. Okay, I'll choose some different pen. You see this front image. First image is showing you frontal bossing. Frontal bossing, soft skull bones. Brain is growing rapidly. Ankita ji, but why are you so scared? No, not at all. पास करना है वो भी 200 प्लस नंबरों से. स्केर्ड वाली बात ही नहीं करनी. Right, so frontal bossing, you see the skull is being distorted. Image, these are all the important images which they might ask you in the topic of orthopedics and the topic of pediatrics, right? Next is Harrison sulcus. So you see there is a groove, there is a line like structure between chest and abdomen. Harrison sulcus, Harrison groove, whatever you want to call it, right? Harrison sulcus. Now, what you can see over here. Here you see knee joint, right? Now, what you do is you look distal to the knee joint. Distal to the knee joint. What structure is present distal to the knee joint? Feet. Now feet, you see they are going towards the midline. Feet, they are going towards the midline. But on the second hand, on the left side, the feet, they are going outward. And here, feet, they are going inward. So what am I trying to say? On the left side, your patient has deformity called genu valgus, right? On the right side, your patient has deformity called genu varum. So when two deformities are present in one patient of yours, आपके एक ही patient में दोनों deformities हैं, right? So what is that called as? That is called as wind sweep deformity. Wind sweep deformity. What question do they ask you? What is the most common cause? Most common cause of wind sweep deformity is rickets. Fine. What is the most common cause in adults? What is the most common cause in adult? Most common cause in adults is rheumatoid arthritis, wind sweep deformity. Valgus in one limb and varus in the other limb. Valgus in one limb and varus in the other limb. Now, I want you to focus on hips of the child. I want you to focus on hips of the child. On the right side, the child has genu varum. But you notice something else, that the child also has coxa valga. Child also has coxa valga. Whereas on the left side, the child has coxa vera. Coxa vera. So these two deformities are often present together. For example, coxa vera is often present with genu valgum. Is often present with genu valgum. And coxa valga is often present with genu varum. Is often present with genu varum. मतलब आपके मरीज में अगर कॉक्सा वैल्गस है तो जीनू वेरम जरूर होगा साथ में. अगर आपके मरीज में कॉक्सा वेरा है तो जीनू वैल्गम जरूर होगा साथ में. राइट जी. Okay, continuing with the rickets, let's move forward. So what do we have here? This particular thing is rachitic rosary. Fine. So remember here we have to study two type of rosary, rachitic rosary, fine, and the other one is scorboutic rosary, right? Rachitic rosary, remember it is painless, and here this is painful. Okay, here this is round, and here this is angular. Question bhi hai, question bhi discuss karenge, don't worry. First, a quick revision, right? Extremely ultra rapid revision of all the important images, all the name fracture, all the splints, all the classifications. बिकॉज पिछले से पिछले नीट पीजी में क्लासिफिकेशन पूछी थी उन्होंने. इस बार हम सारी क्लासिफिकेशन पढ़ेंगे फटाफट से. राइट नाउ हियर, so you see here the child has got this typical deformity called as genu valgum, right? In the second image, the limbs are going, the feet are going inward. So that means the child has got deformity, genu verum. Now they ask you this question that genu verum is common in which arthritis? It is common in osteoarthritis. They ask you this question, genu valgum is common in which arthritis? It is common in rheumatoid arthritis. It is common in rheumatoid arthritis, right? Okay. So, dear doctors, what do you get to see over here, right? So you get to see this first one. So that is cupping of metaphysis, right? Then you see this widening. So this is splaying of metaphysis, right? Then you get to see the third thing, the rough edges. So what are these rough edges? That is fraying of the metaphysis. So cupping, splaying, and fraying of metaphysis you get to see in rickets, right? And this is white line of Frankel. This is white line of Frankel. Okay, so earliest it is seen at 6 to 7 weeks, and it is seen at wrist joint. It is seen at wrist joint. Fine, wrist joint. Okay, then in 100% of patient it is seen by 6 months. It is seen by 6 months, right? Okay, 100% of the patient. Now they ask you that phosphate levels, when do they begin rising after you start the treatment? Phosphate levels, they begin rising within 96 hours. What is the time of surgery? Time of surgery is when the child has attained skeletal maturity. When the child has attained skeletal maturity. Okay, अल्कलाइन फॉस्फेटेज नॉर्मल होना मतलब आप ब्रेसेस यूज कर सकते हैं, लेकिन सर्जरी करने के लिए आपको वेट करना पड़ेगा जब तक बच्चे की बॉडी मैच्योर नहीं हो जाती, राइट? ओके, now this is about osteomalacia. This is about osteomalacia. So what do you get to see here? Osteomalacia, you get to see typical tri-radiate pelvis. You get to see typical tri-radiate pelvis. कई कई बड़ी किताबों में इसका नाम ओटो पेल्विस भी दिया गया है. ओटो pelvis, tri-radiate pelvis, also called as Ortho pelvis. Okay, and what do you get to see here? These are called as pseudo fracture. These are called as milkman fracture. Fine. Dr. Milkman discovered these fracture. So what is the most common site? Most common site is neck of femur. They are common in the lower limb. Osteomalacia कॉमन किस में है? इट इज कॉमन इन विमेन ऑफ डेवलपिंग कंट्रीज. इट इज कॉमन इन विमेन ऑफ डेवलपिंग countries. Fine. Osteomalacia, drugs which are commonly responsible. Anti convulsants, ये आपको याद रखना है जी. Anti-convulsants, antacids, heavy metal जैसे cadmium, heavy metal जैसे cadmium, right? So these are some of the common drugs which cause osteomalacia, right? थोड़ा सा अपने को स्पीड बनाए रखनी है बस, ताकि ज्यादा से ज्यादा टॉपिक कवर कर सकें, ज्यादा ज्यादा टॉपिक रिवाइज कर सकें. जो भी आपका क्वेरी है, जो भी आपका डाउट है, जो टॉपिक आपको मुश्किल लगता है, दैट आई विल एक्सप्लेन फाइन एट द एंड ऑफ द क्लास. Okay, now osteoporosis. So what do you get to see here? Osteoporosis. This one is typical Dowager hump deformity. Dowager hump deformity. Typical Dowager hump deformity. आप बंदा आगे झुक के चलता है, right? Now, what do you get to see over here? This one is fish mouth vertebra, also called as codfish vertebra. Now, this is seen when 30 to 40% of the bone mass is lost. 30 to 40% बोन मास जब खत्म हो गया, तब जाके दिखना शुरू होगा कॉडफिश वर्टेब्रा. सो वी नीड सम बेटर इन्वेस्टिगेशन. एंड व्हाट इज द बेटर इन्वेस्टिगेशन? डेक्सा, डुअल एनर्जी एक्सरे अब्जॉर्पिटोमेट्री. डुअल एनर्जी एक्सरे अब्जॉर्पिटोमेट्री, ये हमें दो स्कोर देगी जी. ये हमें देगी टी स्कोर और जेड स्कोर. टी स्कोर एंड जेड स्कोर. सो टी स्कोर कैसे मिलेगा? टी स्कोर व्हेन बोन मिनरल डेंसिटी ऑफ योर पेशेंट इज मेजर्ड विद someone who is younger. आपके मरीज की बोन मिनरल डेंसिटी जब आपने किसी जवान आदमी के साथ कंपेयर करी, जवान आदमी या जवान औरत, ऑफ कोर्स आपका पेशेंट मेल है, सो यू विल कंपेयर द बोन मिनरल डेंसिटी विद अ यंगर मेल. Your patient is a female, you will compare the bone mineral density with a younger female, right? Now, Z score. At the end, everything is the same. So, Z score. Z also comes at the end. So, that means you will compare the bone mineral density with race, gender, and age matched individual. Age match individual. What is more important? More important is T score. So when the T score is between minus 1.5 to minus 2.4, we say that our patient has got osteopenia. When it is less than minus 2.4, we say that our patient has developed osteoporosis. Our patient has developed osteoporosis, right? Now, osteoporosis, fractures are very, very common. What is the name of the fracture? Fragility fracture. Where do they occur? They commonly occur at dorso-lumbar spine. They commonly occur at neck of femur. They commonly occur at the wrist joint. They occur at the wrist joint. Fine. Fragility fractures. Now, what is the treatment? You need to remember three categories of drug. Fine. First, they inhibit osteoclast. Fine. Bisphosphonate. Remember, you need to remember the name: alendronate, risperidone, ibandronate, zoledronate. Now, these two, they can be given every week. Ibandronate can be given every month. Zoledronate can be given every year. साल में सिर्फ एक बार देना है zoledronate, काम खत्म. Right? Good evening, sir. Wow, wow. Thank you, Jay. Ayush. Okay, okay. That's great. That's great. Congratulations, sir. Congratulations. आइए, मेरे डिपार्टमेंट में एसआरस की जरूरत है, आप यहाँ पे ज्वाइन कीजिए प्लीज. थोड़ी देर के लिए. Right? Bisphosphonate, calcitonin, second drugs. Okay. Then estrogen. Okay, as a part of hormone replacement therapy, selective estrogen receptor modulators. Okay. denosumab. So these are the drugs which decrease osteoclast activity. Then we have drug which increase osteoblast activity, and then these are dual action drugs, but we don't use them very often because you see they are nephrotoxic. They are nephrotoxic, right? Okay. Then what do you get to see over here? So that is called as endo bone appearance, bone within bone appearance, bone within bone appearance. Of course it is seen in osteopetrosis, of course it is seen in osteopetrosis, right? And what do we get to see over here? We get to see something which is called as Erlen Mayer flask deformity, Erlen Mayer flask deformity. These are typically seen in osteopetrosis. These are all so important images कि इसके बारे में आप भूलने का सोच ही नहीं सकते बिल्कुल भी. अच्छा, मेरे को क्लास में ना कई बार काफी स्टूडेंट्स ने बोला कि सर रिकेट्स में और इसमें कंफ्यूजन होती है. कोई कंफ्यूजन का सोर्स नहीं. रिकेट्स में आपके पेशेंट की बोन्स अपनी शेप मेंटेन रखेंगी लाइक दिस, राइट? बहुत छलांग मारी तो थोड़ा बहुत वो फैल जाएंगी, लेकिन कहाँ फैलेंगी? नीचे वाले हिस्से में. रिकेट्स में all the changes they are limited to metaphysis, right? Whereas in osteopetrosis, changes they even extend up to diaphysis, even extend up to diaphysis. अब देखो जी, ऊपर तक चली गई, fine. So you see this thickness is extending up to diaphysis also. So that is the shape of bone in rickets, and this is the shape of bone in osteopetrosis, marble bone disease, marble bone disease, fine. Marble bone disease. What is the treatment? Treatment क्या है? Treatment is stem cell transplantation, stem cell transplantation. Okay. Next they ask you what is the common cause of death. Common cause of death is increased susceptibility to infections, increase susceptibility to infection. What other striking clinical features are present? Hepatomegaly, striking clinical feature, hepatomegaly, right? That was osteopetrosis, marble bone disease. लो जी, ये अगला क्या आ गया? When your patient has so thick bones, so damn thick bones, we know, जिन्होंने पढ़ा हुआ है उनको तुरंत से पता लग जाएगा कि हम किस चीज का जिक्र करने वाले हैं. We begin discussing now Paget disease. Paget disease, always present in your patient who are more than 50 years of age. 50 years of age. Male female incidence equal. Male female incidence is equal, right? Just cough for yes, yes, yes. Okay. Now, the three phases. First one you see is the lytic phase. Fine. Then you see is the blastic phase. Okay. Then the third last one is the sclerotic phase. Sclerotic phase. Okay. Now this you get to see in the lytic phase when the bone is being destroyed. Okay. Then this, what do you get to see? So this is called as candle flame sign. Candle flame sign. You see here, candle flame can very easily fit inside. Candle flame can very easily fit inside. Candle flame sign, right? Now candle flame sign only is also called as blade of grass sign. I'll show you that. I'll show you that. Then we get to see cotton wool skull. What exactly is cotton wool skull? Cotton wool skull is thickened skull bones. Thickened skull bones. Cotton wool skull. Okay. Then what changes do we see in the spine? So in the spine we get to see something very typical, and that is called as picture frame vertebra. Picture frame vertebra. I'll erase it so that you can appreciate the picture. Picture frame vertebra. Fine. Picture frame sign typically seen in Paget disease. In the later stages, what we get to see, that is called as ivory sign. Ivory sign. Okay, what kind of fractures are common? Transverse fracture, which are also known as banana fracture. Transverse fracture, which are also known as banana fracture. They're commonly seen in this disease. Right now, Paget disease over. What we get to see, the next one is achondroplasia. Achondroplasia. So achondroplasia. I'll appreciate that if you can answer me. Otherwise, I'll continue to answer. Fine. Achondroplasia. Autosomal dominant. What is the gene mutation? Anyone? Gene mutation is FGFR3. Fine. Fibroblast growth factor 3 gene mutation. It is the most common cause of genetic dwarfism. What do you get to see here? Starfish hands. So you see all the digits. They are of equal size. All the digits, they are of equal size. Fine. Then what do you get to see here? These are trident hands. Trident hands. So if you can notice, index finger, middle finger, ring finger, little finger, there is very wide gap between middle finger and ring finger. So this happens to be your typical trident hand. Trident hand. Simian crease. So there is a single prominent crease on the hand. Single prominent crease on the hand. Champagne glass pelvis of achondroplasia. Apart from this, you know, we get to see something called as chevron sign. We get to see something called as chevron sign. When I will send the PDF, I'll share this picture of chevron sign also. Fine. But just in case I forget, please Google the image. Chevron sign, achondroplasia, important sign. What kind of pelvis do we have? We have got champagne glass pelvis, which is very, very wide, but not very tall. Not very tall. Champagne glass pelvis. Okay. Definitely, sir. Definitely. वर्मा जी, वर्मा जी एक काम करते हैं, इसके बाद ही कर लेते हैं, नेक्स्ट स्लाइड पे जाने से पहले फटाफट ये वाला आपका काम कर लेते हैं पहले। ओपन रिडक्शन इंटरनल फिक्सेशन, क्लोज रिडक्शन इंटरनल फिक्सेशन कर लेते हैं, अभी कर लेते हैं। राइट, यस डॉक्टर रितेश जी, एक्चुअली मुझे फोटो लगानी चाहिए थी, मैं लगानी भूल गया जी। सो व्हाट डू वी हैव हियर? वी हैव गॉट bullet shaped vertebra. Again they ask you the term that what is the pattern of deformity? Rhizomelic micromelia. Rhizomelic micromelia. Okay, लो जी, अब अपने वर्मा साहब की बात हमारे सुन लेते हैं। कंसिडर दिस ओपन रिडक्शन इंटरनल फिक्सेशन। सी, ओपन रिडक्शन internal fixation, right? Let's understand the meaning of each of these terms. Open reduction, internal fixation, right? So you see the word open is that we gave an incision. Reduction, now suppose, dear doctor, that these two bone fragments were present far away. Now you bring them close together. That is reduction. Internal fixation. Internal means the incision is closed with sutures. Fixation, let's say the two broken fragments. So what you have used? You have used a plate and screws. That is fixation. Open reduction, internal fixation. Right? Then open reduction, एक्सटर्नल फिक्सेशन, बाकी सब कुछ सेम है। व्हाट इज द मीनिंग ऑफ एक्सटर्नल? So what we do is we leave the wound open. कब करते हैं हम लोग? When there is risk of infection. When there is risk of infection, we leave the wound open. External fixation. We will give incision. या तो हम चीरा देंगे और there is an open wound. There is an open wound. Fine. Open reduction. Reduction is the same. Reduction में same. To bring both of them together. दोनों को पास लेके आना. Fixation is also same. Only thing is that we will not close the incision. We will leave the incision open. We will leave the incision open. अच्छा. Closed reduction. Closed reduction. ये कब करेंगे? Suppose that means no incision is given. No incision is given. Fine. या तो incision बिल्कुल ही नहीं दिया, अगर दिया है तो बहुत ही छोटा सा incision. This is commonly done in dislocation. This is commonly done in dislocation. Remember, what is the most common joint to undergo dislocation? Shoulder joint. Fine. So what we do is, without giving any incision, we reduce the dislocation. So close reduction. Close reduction. Is close reduction plus internal fixation possible? Yes. For example, you give, let's say, here. Here. Now suppose the bone is fractured. Suppose you give an extremely small incision here, and through this you insert cancellous cannulated screws. That would be close reduction internal fixation. Close reduction internal fixation. Yes, Dr. Ayushi, bilkul, exactly. Okay, so close reduction internal fixation. Okay, now, so remember, dear doctors, you must have you must have read about fracture of necessity. So these are the fractures where surgery is necessary. These are the fractures where surgery is necessary, is absolutely necessary. Fine. For example, here, Galeazzi fracture, lateral condyle of humerus fracture, lateral condyle of humerus fracture. So these are the fractures where there is dislocation already present. Dislocation is already present. Lateral condyle of humerus fracture. Even supracondylar fracture of humerus. Supracondylar fracture of humerus. Neck of femur fracture. So these are the fractures where surgery is necessary. For example, Galeazzi fracture. There is dislocation. So you will have to reduce the dislocation. Right? Lateral condyle of humerus fracture, there is very high chance of non-union. So you will have to do surgery, otherwise fracture jodega nahi. Now, supracondylar fracture, there is very high chance of malunion. You will have to do surgery, otherwise haddi tedi medi jud jayegi. Neck of femur fracture, especially intracapsular. Surgery is definitely necessary, because you see, otherwise there is very high risk of non-union. So surgery, here you will have to perform. Here you will have to perform. Okay. Confusing where to, which to use one. वर्मा जी, एक्सटर्नल फिक्सेशन इंटरनल फिक्सेशन तो डिसाइड हो गया. जहां पे ओपन वुंड है, खुला जख्म है, रिस्क ऑफ इंफेक्शन है, वहां पे ओपन फिक्सेशन. Right, where you have given the incision, you will give the incision only inside sterile OT. साफ सुथरे OT में आप ऑपरेट करोगे, बड़े डॉक्टर साहब हैं आप, तो तब आप क्लोज रिडक्शन करेंगे. क्लोज रिडक्शन इंटरनल फिक्सेशन. Right, but when there is an external big wound, high chance of infection, then you will do external fixation. Right जी, ये आती है, बहुत लोगों में कंफ्यूजन आती है ये. आई मीन यू नॉट द ओनली वन, ओके। अच्छा सर, एक क्या था कि मैंने देखा कि पिछले जो 2024 वाले नीट पीजी में उन्होंने एक क्लासिफिकेशन सिस्टम पूछा था, तब से मेरे मन में डर बैठ गया कि वो लोग कोई भी क्लासिफिकेशन सिस्टम पूछ सकते हैं दोबारा से, राइट। तो क्या पढ़ेंगे अभी, सॉल्टर हैरिस क्लास, सारे क्लासिफिकेशन सिस्टम क्विकली एक बार देख डालेंगे फटाफट से, फाइन। सॉल्टर हैरिस क्लासिफिकेशन, सॉल्टर हैरिस क्लासिफिकेशन इज फॉर फाइशियल इंजरीज, फाइशियल इंजरीज, फाइशियल मतलब ग्रोथ प्लेट इंजरीज, ग्रोथ plate injuries, right? Now you see here, one, type 1. What exactly is type 1? Now see dear doctor, this is epiphysis, this is physis, this is metaphysis, right? Now here simply what happens is that metaphysis is separated from the physis, metaphysis is separated from the physis. So this is very similar to slipped capital femoral epiphysis. Type 1 Salter Harris classification is very similar to slipped capital femoral epiphysis. Fine. Type 2 is the most common. Type 2 is the most common. So there is fracture above the physis. There is fracture above the physis. Fine. L means low. So there is fracture below the physis, below the physis. Type 4. So there are two fractures. One fracture is above the physis, other fracture is below the physis. Fine. And R means raised. Raised matlab रौंद dena, gira dena. So here growth plate, or what we call as physis, is completely crushed. Growth plate, or what we call as physis, it is completely crushed. Yes, sir. Ayush ji, white line of Frankel. You know, white line of Frankel, it is seen in scurvy as well as in rickets. You know, in scurvy, there is no deficiency of calcium, there is deficiency of vitamin C. So there also white line is seen. In rickets, it is only seen if there is healing rickets. In healing rickets, we get to see white line of scurvy, a white line of Frankel, whereas in scurvy, we continuously see white line of Frankel. So it is seen in both, right? Okay, then we have got Gartland classification. We have got Gartland classification, supracondylar fracture of humerus. Gartland classification. Gartland classification 2024 में भी आई थी, 25 में भी आई थी, right? Okay, so type 1, incomplete fracture. Fine. Type 2, posterior cortex intact. Posterior cortex intact, complete fracture. And type 4 is complete instability, complete instability in all direction. हड्डी बस कहीं भी किधर भी घूम रही है, राइट। गाटलैंड क्लासिफिकेशन, आपको डिटेल नहीं याद रखनी, कोई बात नहीं, जस्ट रिमेंबर व्हाट इज द यूज ऑफ गाटलैंड क्लासिफिकेशन, राइट। नीचे लिखा हुआ है वैसे, राइट, एवरीथिंग इज रिटन, undisplaced, displaced, okay, completely displaced fracture, okay. Then we have got Garden classification. Garden classification is for neck of femur fracture. It is for neck of femur fracture. So you see here Garden classification. The first one, again as always. So first one is undisplaced incomplete fracture. Second is complete fracture but no displacement. Third is complete fracture but minimal displacement. And fourth is complete fracture, complete displacement. Garden classification. Next, dear doctors, is Powell classification. Powell classification, it is based on angle of fracture line with horizontal line. Fine. So you see here, this fracture is stable and this fracture is unstable. Stable and unstable fracture. right? Powell classification. Now, this one, what we are discussing here is Neer classification. Neer classification of proximal humerus. Neer classification of proximal humerus. Remember, humerus is bone of the arm. So, proximal humerus, axillary nerve is injured. Mid-humerus, radial nerve is injured. Distal humerus, median nerve is injured, and ulnar nerve is injured. So Neer classification, one part, two part, fine, two part, and then three part, then four part. One part, two part, three part, and four part, right? Okay. So Neer classification, right? One part. Okay, but you see here they are separated from each other. That is why it is called as two part. And in the third image, see, they all are separated from each other. So three part, and then all separated. So four part, right? Neer classification. डिटेल नहीं याद रखनी, कोई बात नहीं, सिर्फ नाम याद रखिए, वो भी बहुत है. शार्ट्सगर क्लासिफिकेशन, दिस इज फॉर द सरप्राइज एलिमेंट कि कोई सांप निकाल दिया एकदम से एग्जामिनर ने. So this is for tibial plateau fracture, tibial plateau fracture, right? Schatzger classification. Mason classification is for radial head injury. Again, you know, this is less important, but examiner का पता कुछ नहीं, तो नाम याद करने में कोई बुराई नहीं. Young and Burgess classification. Young and Burgess classification is for pelvis ring. Remember, Young and Burgess से पहले आती थी अपने पास tiles classification. That has been replaced by Young and Burgess classification. Right? Catteral classification is for leg calf Perthes disease. Leg calf Perthes disease. Catteral classification. Catteral classification. Okay. Castillo-Anderson classification. This is for open fracture. Open fracture, which is also known as compound fracture, which is also known as compound fracture. So you see here we have got different type. One, the wound is less than 1 centimeter. Two, the wound is between 1 to 10 centimeter. And third, there is a big wound, A, B, C. Fine. So A means there is adequate periosteum present. Fine. B, that means there is too much bacterial contamination. C, circulation is completely cut. Circulation is completely cut. Castillo-Anderson classification. राइट जी, ये क्लासिफिकेशन सिस्टम अपने को पढ़ने हैं जी, इंपॉर्टेंट है, हर हालत में याद रखने हैं प्लीज. नाउ वी विल क्विकली सी द इम्पॉर्टेंट फ्रैक्चर, वेरी वेरी क्विक रिवीजन ऑफ ऑल द इम्पॉर्टेंट फ्रैक्चर, उसके बाद थोड़े से क्वेश्चन करेंगे. राइट, सो बी आपने कैसे याद रखना है? बी फॉर बिग फ्रैक्चर एट द नी, दैट वुड बी बम्पर fracture. Big fracture at the knee, that would be bumper fracture. Bumper fracture, right? कैसे होता है देख लो. This is bumper fracture. Okay, femur, tibia, and here there is a fracture. Okay, now this is how your patient will sustain the fracture. Bumper fracture, that is why it is called as bumper fracture. Then S for second. So S means if there is small fracture at knee, that would be second fracture. Why this is important? Because this is associated with anterior cruciate ligament injury. This is associated with anterior cruciate ligament injury. Such a small fracture, barely visible, small fracture. right G? Galeazzi fracture dislocation. Remember here there are 100 plus mnemonics. Everyone has their own mnemonics. But what is the simplest mnemonic? Simplest mnemonic is GFR. Galeazzi fractures radius. Galeazzi fractures radius. Just a minute, मैं फोन अपना बंद करना भूल गया था जी, sorry. Really sorry for this interruption. Galeazzi fracture. Fine. Then we have got another mnemonic, Murg. Fine. So Monteggia will fracture ulna and Galeazzi will fracture the radius. Galeazzi will fracture the radius. Murg. That's another mnemonic. Okay. Then you see there is another mnemonic called as Grimus. Galeazzi will fracture the radius at inferior position. Inferior means distal position, right? And Grimus. So Monteggia will fracture the ulna at superior position. Will fracture the ulna at superior position, right? That's the way to remember Galeazzi fracture. Now you see here, this bone is radius, this bone is ulna, and as you can see, there is wide dislocation. There is wide dislocation. What is there is a patient repeatedly calling me. Please allow me to check. Please allow me just for 1 minute. आई वो वापस से किसी को लिप रीडिंग नहीं आती है. Patient was calling me incessantly. 4 फोन 5 फोन. आई गॉट स्कैर्ड और वो बोले डॉक्टर साहब फॉर्म पे साइन कराना था. उसके लिए 4 5 फोन कौन करता है जी. Okay, so this is Galeazzi fracture, right? Then Monteggia fracture. So as you can see here, ulna is perfectly okay. Ulna is perfectly okay, and then you can see the radius is fractured. Radius is fractured, right? Now you see there is dislocation. There is dislocation. This is the Monteggia fracture dislocation. Monteggia fracture dislocation. Okay. Then nightstick fracture. So as you can see, there is absolutely no dislocation. Absolutely no dislocation. And then here there is a fracture. I'm sorry. So there is an isolated fracture. There is an isolated fracture of the ulna. Nightstick fracture, right? Then we have got another fracture called Barton fracture, right? Now here, let me just go slightly forward and we'll quickly revise it. Now, you see here. So, as you can see here, if my hand goes like this, that is dorsal angulation. If my hand goes like this, that is ventral angulation, also called as volar angulation. Fine. So once again, neutral position. If my hand goes like this, dorsal angulation. If my hand goes opposite side, that would be volar angulation. Volar angulation, right? So let's say if your patient has got fracture, if your patient has got fracture like this. So if your patient has got fracture which is extra articular, so extra articular fracture plus dorsal angulation that becomes Colles fracture. Extra articular fracture plus ventral angulation, also called as volar angulation, that becomes Smith fracture. Fine. Now if there is intra-articular fracture like this, So let's say there is a fracture like this. Right? The fracture line, it is running across. I'm sorry, I'll draw. So let's say the fracture is like this. Intra-articular fracture. This becomes Barton fracture. This become Barton fracture. If it goes like this, Barton fracture, fine. And if it goes like this, that becomes Voller Barton fracture. Voller Barton fracture. अच्छा जी, वो अपने डॉक्टर साहब हैं हमारे Atul ji is asking about something reallocation. If somebody can please answer him, reallocation of centers. Now, Bennett fracture. Bennett fracture is most common fracture of the base of thumb. And what kind of fracture it is? It is displaced fracture. It is displaced fracture. Displaced fracture. Right? Bennett fracture. Bennett fracture is displaced, and Rolando fracture, what it is? It is comminuted. Comminuted means there are many fragments. बहुत सारे टुकड़े, many fragments. Right? Schoffer fracture, also called as backfire fracture. It is the fracture of styloid process of radius. Fine. Colles fracture. Colles fracture, you need to remember the word slip. Your patient will come to you with supination. Your patient will come to you with lateral angulation. Fracture will be impacted. Fine. And there will be posterior shift. देखो जी, हड्डी टूट के पीछे की ओर चलेगी. That is posterior shift. What is the treatment? Treatment is propaganda, pronation, palmar angulation, and ulnar deviation. Propaganda is the treatment. Yes, 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 Dr. Tejas ji. In my humble opinion, this is okay. Now, this one is fifth, but please do read notes. Either my notes or someone else's note. Do read your notes. Fine. I mean the complete ones, not the rapid revision session. Rapid revision session are just for brushing up. You can't rely upon them completely, Dr. Tejas ji. Fifth, metacarpal fracture. What is the treatment? Treatment is ulnar gutter splint. Ulnar gutter splint. That's a treatment. Holston-Lewis fracture. Holston-Lewis fracture is mid-shaft radius fracture. Mid-shaft radius fracture plus radial nerve injury. वही गलती क्लास में, वही गलती यहाँ. It's a mid-shaft humerus fracture. I'm sorry. Mid-shaft humerus fracture. Plus there is radial nerve injury. Right? Mallet finger, as you can see, rupture of extensor tendon. Treatment is we keep the finger straight. We keep the finger straight. That is why we use stacks splint. That is why we use stacks splint. Stack splint is the name, right? Mallet finger. Gamekeeper thumb. Gamekeeper thumb is, it's not acute. Gamekeeper thumb is chronic injury. Chronic injury to ulnar collateral ligament. What is acute injury? Acute injury is skier thumb. Acute injury is called as skier thumb, right? Chopard fracture dislocation. So you see, dear doctors, here up to these, what kind of bones are present? Metatarsals. Beyond these, what kind of bones are present? Tarsal. right? And there is fracture between them. There is fracture between them. So choppered fracture is also called as transtarsal fracture. Is also called as transtarsal fracture. Transtarsal fracture, right? Cotton fracture. So you see here, pod fracture bimalleolar and cotton fracture trimalleolar. Trimalleolar. This is important. Cotton fracture, pod fracture. Okay. Trimalleolar. देखो, fracture, fracture, and posteriorly also there is fracture. Cotton fracture. Shepherd fracture. So you see there is fracture of talus. Fracture of talus. Shepherd fracture, not very important. Shepherd fracture. The fourth, not important. Lisfranc fracture, yes. So as you can see over here, up to these, what kind of bones are present? Metatarsal. And beyond these, what kind of bones are present? Tarsals. So there is joint. So there is fracture dislocation at tarso metatarsal joint. Fracture dislocation at tarso metatarsal joint. Lisfranc fracture. Lisfranc fracture. Straddle fracture. So there is bilateral fracture of superior and inferior pubic rami. Inferior pubic rami. Straddle. घोड़े के ऊपर बैठने वाली काठी, उसको हम लोग बुलाते हैं जी straddle. Right? Jefferson fracture. Jefferson fracture is C1 burst fracture. How can we see it? Open mouth odontoid view. Open mouth odontoid view on X-ray. Right? Open mouth odontoid view on X-ray. Jefferson. Hangman fracture is C2 fracture. So what happens is C2 slips over C3. That means it is a type of spondylolisthesis. It is a type of spondylolisthesis. One vertebra slipping over the other. One vertebra slipping over the other. Spondylolisthesis. Clay-Shoveler fracture. C6 or C7 fracture. Right? Now, if your patient is already dead, then that will be called as undertaker fracture. Undertaker fracture. Okay. Clay-Shoveler fracture. C6 or C7 avulsion fracture. Chance fracture. Remember, chance fracture came in this year exam. Chance fracture is also called as jackknife fracture. Jackknife क्या? रामपुरिया चाकू. वो खोल के बंद हो जाता है, जो फोल्ड हो जाएगा फिर खुल जाएगा. Jackknife fracture. So anterior part of spine fractured. Middle part of the spine fractured. Posterior part of the spine fractured. So this is an unstable injury. Jackknife fracture. Here, what do you get to see? So here what we get to see is something called as buccal fracture. Buccal fracture, also called as torus fracture. Torus fracture. So you can see here that bone is bent. आप इधर देखिए, sorry, इधर देखिए, bone is bent. Torus fracture. So here, torus fracture. Right? Why it is called as torus fracture? You see, पिलर के नीचे जो गोल गोल जगह है, इसको हम लोग टोरस बुलाते हैं. It is called as torus fracture. So it is buckling fracture. Buckle. Now, the deformities in rheumatoid arthritis. So if your patient has flexion at DIP, mallet finger. If your patient has flexion at PIP and hyperextension at DIP, that is called as boutonniere deformity. If your patient has flexion at DIP and hyperextension at PIP, that is called as swan neck fracture. Now, what do we get to see over here? So you notice that there is flexion at DIP. You notice there is hyperextension at PIP. So this is very typical swan neck deformity. Very typical swan neck deformity. Okay. Now here, what kind of deformity is this? This kind of deformity is called as hammer toe deformity. Hammer toe deformity. Hitchhiker thumb. Permanent extension deformity of the thumb. Hitchhiker. Right. Z deformity also it is called. Outbridge classification, it is for osteoarthritis. It is for osteoarthritis. Just remember the name, nothing else. Fine. This is what we get to see on osteoarthritis. Fine. So on osteoarthritis, what do we get to see? Decreased joint space, more on the medial side than on the lateral. More on the medial side. You see here. On the medial side, you can see that there is absolutely no space. And here you can see there is still some space. There is still some space. Right. Then the next thing which you get to see is osteophyte. Osteophyte. Now, osteoarthritis, it is common in obese elderly male. Common in obese elderly male. They ask you the question, what is the most common joint? Most common joint is hip joint around the world, and it is knee joint in India. Knee joint in India. Right. Now, psoriatic arthritis. What do we get to see? We get to see sausage fingers. We get to see sausage fingers. आपने जो लोग नॉन वेजिटेरियन है चिकन सॉसेज खाए होंगे. So it appears like this. It appears like this. Sausage finger. Then on X-ray we get to see pencil cup deformity. Pencil cup deformity. This is what we get to see on the X-ray. Pencil cup deformity. Pencil. So you see this is the pencil and this is the cup. Pencil cup deformity. Pencil cup deformity. Pencil cup deformity. Right. Then ankylosing spondylitis. Ankylosing spondylitis. You need to remember the name of the test. So Ganseland test, it is for sacroiliac joint. It is for sacroiliac joint. Ganseland test. Another test for sacroiliac joint is Faber test, also called as Patrick test, also called as figure of 4 test. Then for lumbar spine, what is the name of the test? For lumbar spine, name of the test is Scober test, modified Scober test. Okay. Now here on the X-ray side, what do you get to see here? First thing which you get to see is squaring of the vertebra. Squaring of the vertebra. Right. Then you get to see bamboo spine. Bamboo spine. All the vertebra you see they have fused with each other. सारे एक दूसरे के साथ जुड़ गए. Right. Yes. डॉक्टर साहब कौन है हमारे? Dr. Ritesh ji. Yes. More than 90% of the patient they are associated with HLA B27. Now, if you see a white line in the middle, what does that make? That makes it dagger sign. That makes it dagger sign. Right. If you see white line on the side, that makes it rail railroad sign. If you see both white line, that makes it trolley track sign, right? Okay, फटाफट से दो चार क्वेश्चन, राइट? यस, प्लीज टेल मी द आंसर. मैं आपके लिए पढ़ देता हूं, थोड़ा सा समय बचे. So you see an obese 14-year-old, मतलब क्या है ये? adolescent है. adolescent. एक मिनट पानी पी लिए. Okay, adolescent boy presents with 3 weeks of groin pain and referred knee pain. He can still, I need some water please. He can still walk with a limp. So adolescent plus pain plus limp. Okay. For confirmed it's inferior slip with the capital femoral epiphysis. The diagnosis is slipped capital femoral epiphysis. And what is the treatment? Close reduction and pinning. Close reduction and pinning. So this is not the right answer. Fine. In situ screw fixation, right? So this would be the right answer. In situ means inside. Yes. No. Fever. Thigh pain. When we say thigh, that means we are talking about diaphysis. Raised ESR and leukocytosis. Permeative means inserting. Diaphysis with layered periosteal reaction. MRI shows marrow replacement and large soft tissue component. Blood culture is negative. Child partially improves. So this is just to confuse you. Otherwise, all these things, what are they pointing towards? They are pointing towards Ewing sarcoma. They are pointing towards Ewing sarcoma. Fine. So Ewing sarcoma, first you will confirm the diagnosis. You will confirm the diagnosis with biopsy. You will confirm the diagnosis with biopsy. Right. So you see blood culture is negative. That means chances of infection are very less. Secondly, you will notice one thing, that osteomyelitis occurs at metaphysis, whereas Ewing's, it occurs at diaphysis. Osteomyelitis age is less than 5 years. Ewing's age is between 5 to 15 years. It's between 5 to 15 years. So the age also supports our diagnosis. Hanji. 72-year-old man presents with chronic bone pain. So 72-year bone pain. Skull X-ray shows thickened calvarium with mixed lytic and sclerotic changes. Serum calcium and phosphate are normal, but serum alkaline phosphatase is markedly elevated. That means too much bone formation. Hydroxyproline is increased. That means too much bone destruction. Okay, and there is no M spike. Now, osteoporosis. In osteoporosis, alkaline phosphatase levels are normal. So this is not. There is no M spike, so this is not multiple myeloma. What is this? This is Paget disease of the bone. This is Paget disease of the bone. Paget disease. 72 years of age. Your patient has thickened bone, right? Mixed changes. Serum calcium is normal in the second stage of Paget, right? So osteomalacia, it is commonly seen in younger age group. Fine. So this is a typical case of Paget disease. Again, one more question. 70-year-old man presents with pain and progressive enlargement of the skull. It is called as Tam O Center sign. X-ray shows cortical thickening with coarse trabeculae and mixed changes. Serum calcium and phosphate are within normal limits, but serum alkaline is markedly elevated. So this is Paget disease. And what is the common pattern in Paget disease? Common pattern in Paget disease is normal calcium. Sir, Dr. Durameterji, I'll not lie, this session is definitely not enough. हाँ, अगर आपने पहले पढ़ा हुआ है as a revision, this is okay. As a revision, this is okay. But you must have read from somewhere before. बड़े बड़े टीचर हैं साहब, अपूर्व मेहरा साहब हैं, वो बोनमैन साहब हैं, अपने अब्बास अली सर, इन सबका अगर आपने पढ़ा हुआ है, मेरे से पढ़ा हुआ है, राइट? अगर आपने पहले पढ़ा हुआ है, उसके बाद आप रिवीजन करते हैं ऐसे वीडियो से, देन इट्स ओके, अदरवाइज नहीं. नाउ द इमेजेस. ऑस्टिन मूर पिन. अगर आपने बीच में ये देख लिया पेज जैसा, दैट इज ऑस्टिन मूर. नाउ छोड़ दो. इफ अगर आपने देखा कुछ नहीं है एंड देन यू सी अ थिन वायर, दैट इज कर्शनर वायर. Kirchner wire, thin wire, Kirchner wire. Steinman pin. So Steinman pin is same as Kirchner wire, but it is thick. थोड़ी मोटी है. Don't worry. आपको एक तार दिखा के कोई ये नहीं पूछेगा कि ये वो है जी स्टीनमैन पिन है कि कर्शनर वायर है, ऐसा क्वेश्चन नहीं आएगा. डोंट वरी, छोड़िए. Crutchfield tong. Crutchfield tong. So Crutchfield tong, it is for skeletal traction. It is for skeletal traction. Crutchfield tong. Austin Moore prosthesis. So if you see two holes, that is Austin Moore. Moore. Okay. Now, if you see single solid body, that is Thompson prosthesis. Single solid body, Thompson prosthesis. If you see that femur head and femur neck are different, that is bipolar hip prosthesis. Bipolar hip prosthesis. Buck traction. So you see the body is angulated. पैर थोड़े से ऊंचे उठे हुए. That is buck traction. रसल ट्रैक्शन, जब मरीज के घुटने को छत के साथ बांधा हुआ होगा, when you know one part is tied to the ceiling, that becomes Russell traction. Russell traction. Now, gallows traction. So you see, if the hips of the baby, they are not touching the bed, that is gallows traction, used for femur fracture. Used for femur fracture. Dunlop is not important. Yes, this image is important. So this image is showing you ring sequestrum. Ring sequestrum. So ring sequestrum is seen with the skeletal traction. It's seen with skeletal traction. So it develops around the skeletal traction pin. Fine. Ring sequestrum. Not important. Yes, Bowler Brown splint. So when you see three pulleys, fine, that is Bowler Brown splint. Bowler Brown. Kramer wire, very very important. Kramer wire splint used for temporary stabilization. Show me braces. Yeah, this Taylor brace. T for Taylor. T for tuberculosis. Taylor brace. Figure of 8 brace used for clavicle fracture. Clavicle fracture. Aeroplane splint. It is used for brachial plexus injury. ये सारी फोटोग्राफ आपने देखनी है जरूर. मैं आपके साथ शेयर करूंगा ये वाली, आपने देखनी है. Von Rosen splint. It is used for developmental dysplasia of hip. Thomas splint, very important. Thomas splint used for hip stabilization. Hip stabilization. Thomas splint. Dennis Brown splint, ultra important, used for club foot. Most common congenital orthopedic disorder in India. Milwaukee brace used for scoliosis. Scoliosis, this is important. Milwaukee brace is important. Boston brace, this is also important. दो तीन चार बार आप देखेंगे, याद करेंगे, अपना निमोनिक याद करेंगे. हाँ मैं दिखा रहा हूँ जी, डॉक्टर साहब जी, डॉक्टर सैयद जी, वही दिखा रहा हूँ. नेक्स्ट वही है सर, वही है. राइट नाउ, so if you see here, it is covering the knee joint. That is called as cylinder cast, also called as tube cast. It is used for patella fracture. ये रहा जी. So you see both of them side by side. If the hand is like this, देखिए डॉक्टर साहब मेरे हाथ को देखिए, अंगूठे को देखिए. If the hand is like this is handshake cast. और भाई साहब क्या हाल चाल, like this, fine. But if the hand is like this is handshake cast. Or this is glass holding cast. I'm sorry, glass holding cast. So if you can see over here, what do you notice? There is ulnar deviation. Remember the treatment, propaganda, ulnar deviation. So this one is handshake cast, and you see this one is glass holding cast. Another thing which you will remember is that in a glass holding cast, thumb is always covered, whereas in handshake cast, thumb is free. Thumb is free. That is the difference, Dr. Saeed ji. The glass holding cast and handshake cast. Fine. That is the difference. Okay. Fracture exercise कर लिया. Okay, right. Now, anything else which you want me to repeat in what they call orthopedics? Otherwise, we'll quickly shift to the next thing, that is wait please, we'll now shift to radio. Please allow me 1 minute. Okay. फ्रैक्चर कौन से हैं? Okay, so you see handshake cast. Handshake cast, it is used for Colles fracture. Fine. Then glass holding cast, it is used for scaphoid fracture. It is used for scaphoid fracture. It is used for scaphoid fracture. The most common carpal bone to get fractured, scaphoid fracture. What is the mechanism? Foosh, fall on the outstretched hands. Dr. Saeed ji, I hope your question was this only, or you had some different question. कोई अलग question है तो बताइए please. Meanwhile, आप लोग इसका आंसर देने का कोशिश कीजिए. It was ultra simple question. Please answer this. So we now have got some 25 questions, important questions coming up. All questions are important. I mean, all topics are important. Please try to answer this question for me. Radio. 62-year-old hypertensive patient presents with sudden right-sided weakness for 2 hours. Non-contrast CT is done first. Which early CT signs suggest middle cerebral artery infarct? Middle cerebral artery infarct. Yes, so dense MCA sign. Remember, blood clot density is much more than the density of flowing blood. Density of flowing blood. So when you get to see the CT scan, when you will get the CT scan, you will see the signs, the clinical features of stroke. There is a mnemonic B fast. So loss of balance, change in vision, face drooping, arms and legs, weakness, speech difficulty. be fast. So at that time, the first investigation which you will get done is CT scan. So the first thing which you will get to see is dense MCA sign. That means you will immediately be able to see a clot in the middle cerebral artery. Clot in the middle cerebral artery. For example, let's say this is the middle cerebral artery. So as you can see here, there is a clot. That means the blood is not freely flowing. So for example, you see here, dear doctor, there is a clot over here. That means blood is not able to flow. So when you get the angiography done, you see there is normal flow on the normal side, whereas there is no flow on the side of blood clot. So this is plain CT scan, and this one is CT angio, right? That is the difference. That is the difference. Okay, dense MCA sign, dense middle cerebral artery sign. Now you see there are zones. So you see the first image is showing you infarct at the level of anterior cerebral artery. Second image is showing infarct at the level of middle cerebral artery. And for the third one, right above my head, you see here, this area is infarcted. This area, as you can see, is infarcted. So this is posterior cerebral artery, posterior cerebral artery. The three clear patterns of infarct. So you see there is a wedge shaped infarct. Wedge shaped infarct. Another thing which you notice here, that gray matter white matter differentiation is gone. Gray matter white matter differentiation is gone. Okay, these are the signs of stroke. Now, if you see here, middle cerebral artery, it has got so many branches, I mean, the branching pattern M1, M2, M3, M4. So let's say if there is a clot over here, fine. In that case, we will get to see dense MCA sign. We'll get to see dense MCA sign. At all places, at all other places, we will just get Sylvian dot sign. So this one is Sylvian. This one is Sylvian dot sign. Sylvian dot sign. So stroke patient, there is a dot, fine, that will be called as Sylvian dot. Consider this as a clot. Sylvian dot sign. Now, in venous sinus thrombosis, you see here. So, when you do the non-contrast CT, remember clot density is high. So, you will get to see something white over here. But when you get the contrast CT, you will see decreased density. Why you will see decreased density? Because there is absolutely no flow. Absolutely no flow because of the clot. Absolutely no flow because of clot. Absolutely no flow because of clot. So empty delta sign, and dense clot sign. Now, in hemorrhagic stroke, you see here fresh blood. Fresh blood will always appear hyperdense, will always appear white, So this one is blood, and around the blood, this. What is this? This is edema. Around the blood, there is edema. Around the blood, there is edema. Now, you see here, there are white areas and there are black areas. So white, of course, is fresh bleed. Black is old bleed. Old bleed. So that means active bleed. Also, we can say re bleed, active bleed or re bleed. Now, ring enhancing lesion. There is a mnemonic, ring enhancing lesion. Magical doctor. Magical doctor is the mnemonic for ring enhancing lesion. Ring enhancing lesion. M for metastatic, A for abscess. So, why ring? There will be pus surrounded by edema, right? Glioblastoma, very aggressive tumor. Infarct, and then inflammation. This could be because of neurocysticercosis or tuberculoma. Contusion, brain injury surrounded by edema. Okay, demyelinating diseases and HIV. HIV related diseases like toxoplasma and cryptococcus, lymphoma and radiation necrosis. So this mnemonic is extremely important for us to remember. Radio पढ़ने के लिए, right? Magical doctor. Okay. Then उस क्वेश्चन में जो हमने पढ़ा अभी, there was a sign, there was a option. What was that? Lemon sign. So you see here, lemon sign is seen on ultrasound when there is pinching, when there is pinching of the frontal bones of the baby, pinching of the frontal bones of the baby. That is called as lemon sign. Lemon sign, pinching. Okay. So you see this, first of all, it is not seen on CT, it is seen on ultrasound, pinching of the frontal bone, and it is seen in Chiari malformation. It is seen in Chiari malformation. अब इतना सब नहीं पढ़ना, इतना याद रखिए. This is seen in neural tube defects. This is seen in neural tube defects, right? Lemon sign. Now, then this is banana sign. So lemon sign is seen in the frontal part. Banana sign is seen posteriorly. Banana sign is seen posteriorly. So you see it is taking the shape of banana. It is taking the shape of banana. Taking the shape of banana, right? Banana sign. Lemon sign and banana sign. Okay, now this question is about the MRI sequences. This question is about MRI sequences. A patient presents with acute hemiplegia. MRI brain is planned to detect ischemia at the earliest stage. Which sequence is most sensitive? Which sequence is most sensitive? Yes, anyone? Please try to answer this question. See, diffusion weighted images, right? Now see, T1 is for anatomy and contrast MRI Fine. T2, it is for edema. TWI, it is also called as stroke sequence. It is also called as stroke sequence, right? And flare, it is for periventricular pathologies. It is for periventricular pathologies, right? Okay, see, T1, how to remember it? T1, एक नंबर आदमी जो सच है वही बोलता है, झूठ कभी बोलता नहीं. और T2, 2 नंबर आदमी, फाइन, इधर भी और इधर भी, राइट? सो यू सी T2. So T1 MRI, gray matter will appear gray white matter will appear white. That is about T1. T2, दो नंबरिया आ गया. दो नंबरिया means चालाक शैतान. So it will be reversed. Gray matter will appear white and white matter will appear gray. Opposite, exactly opposite. Fine. Now another thing जो हम लोग सब अक्सर याद रखते हैं, what is that? The mnemonic is WW2. That means water appears white. Water appears white on T2 images. Water appears white on T2 images. जो ऐसे शैतान लोग होते हैं ना, अपना असली नाम भी नहीं रखते. यूट्यूब के प्रोफाइल पे ऐसे को नाम रख देंगे अलग सा, द ड्यूरा मैटर, है ना, ऐसा को नाम रख देंगे अपना. Okay, see. So these are the images which you see on T1, T2 and flare. T1, T2 and flare. Okay, so T1 is for anatomy and contrast. Fine. T2 is for edema and flare is for periventricular pathology. Periventricular pathology. Fine. So close to the ventricle, if there is any pathology, we will use flare image. Flare image. So flare is basically similar to T2, but CSF in flare imaging, CSF is black. CSF signal is black. Fine. So that's a difference here. Okay. So when we see DWI, diffusion weighted imaging, right? अच्छा, लगे हाथों जरा मुझे एक ये भी बता दो प्लीज. What is the use of short tau inversion recovery? Good evening, G. Good evening, G. What is the use of stir MRI? What is the use of stir MRI? Okay. What is the use of stir MRI? इसके अलावा what is the use of SWI? SWI, SWI MRI. And SWI MRI has got a cousin, GRE MRI. So stir MRI, short tau inversion recovery, is for osteomyelitis, and SWI is for diffuse axonal injury like micro bleeds, right? Diffusion. So whenever there is, whenever there is stroke, brain tissue is dead, there appears cytotoxic edema. Cells, they are swollen. Cells, they are swollen. So there will be restricted diffusion. There will be restricted diffusion. Okay. Now, try to answer this question. 58-year-old male presents with sudden aphasia, stroke, हेमीपेरेसिस फॉर 90 मिनट्स. अभी बहुत कम समय हुआ है. फाइन. MRI brain shows bright signal in the left MCA territory on DWI. So what is appearing bright on DWI should appear dark on ADC and corresponding low signal on ADC map. Flare is normal. What is the most appropriate interpretation? Feature started 90 minutes ago, so it is definitely not chronic. So it is acute ischemic infarct within thrombolysis window. Fine. So usually thrombolysis window is around 4 to 6 hours. So if it is within 4 hours, you will definitely mark the answer as B. Definitely mark the answer as B. Now tumor would have presented in a chronic manner. लंबा history होता. Fine. Subacute infarct with luxury perfusion. Luxury perfusion means still the blood supply is continuing. No, Dr. Vandana ji. For example, you see, let's say foosh, fall on the outstretched hand. It's very common mode of mechanism. In children, it is going to give rise to supracondylar fracture, and in elderly, it is going to give rise to Colles fracture. In young people, it is going to give rise to the scaphoid fracture. Those kind of activities don't give fracture. Now, elderly alcoholic develops gradually progressive headache after minor trauma. After minor trauma, CT scan shows crescent shape extraaxial. You see here, right? Let's say you're looking at the brain. So extraaxial means it is away from the center. It is away from the center. So there is a crescent shape like this. So crescent shape means your patient is having SDH, subdural hematoma. Your patient is having subdural hematoma, right? Subdural hematoma, progressive headache. You know, extradural hematoma, 80% they are associated with fracture. They are common in young. Subdural hematoma, it is common in elderly. It is common in elderly. Epidermoid cyst is not going to cause headache. Arachnoid cyst, of course, can cause headache, but then it will have, gradual feature developing over 6 months to a year or so. A patient presents with sudden severe worst headache of life. Sudden severe worst headache of life. The best initial investigation is MRI brain, non-contrast CT. So initial investigation for any brain pathology, any brain accident, any brain emergency is non-contrast CT scan. Is non-contrast CT scan. What do we get to see? We can get to see something called as star of death. Star of death. Right? Now, they ask you what is the most common cause? What is the most common cause of subarachnoid hemorrhage? Most common cause of subarachnoid hemorrhage is trauma. What is the most common cause of spontaneous subarachnoid hemorrhage? Perianeurysm rupture. Now, here, dear doctors, I'll recommend that you please do read Hunt and Hess scale. Hunt and Hess scale, they tell you about the severity, right? And then Ottawa, capital of Canada, Ottawa subarachnoid hemorrhage rule. They guide whether you should get the CT scan done or not. मरीज आया डॉक्टर साहब सिर में बड़ी जोर की दर्द है. You use Ottawa subarachnoid hemorrhage rules to tell whether CT scan is absolutely required or not. देखो ये वेस्टर्न कॉन्सेप्ट है. हमारे यहाँ तो अभी जाके जितने मर्जी CT स्कैन करा लो, रात को 10 बजे सेंटर खुलवा लो, CT स्कैन करा लो. But in developed countries, getting a CT scan or MRI is a task. 6 महीने बाद की डेट मिलेगी, 2 साल बाद की डेट मिलेगी, right? So they have got special rules that if you fit the criteria of Ottawa subarachnoid hemorrhage rule, only then you will get the CT scan done. Otherwise, it is not required, right? A child presents with seizures. CT brain shows multiple cystic lesion, some with eccentric hyperdense dots. Multiple cystic. Cystic means they are fluid filled, and because they are made up of liquid, they will appear black on CT scan. The eccentric dot represents, बताइए जी, ये तो बहुत एकदम लड्डू वाला क्वेश्चन है जी. So this will be seen in cysticercosis, neurocysticercosis. This will be typically seen in neurocysticercosis, right? Now you see here, fat. Fat will appear black on CT scan. Calcification, of course, will appear white, but here it will not be related to the cyst. So you will get to see a scolex. You see here. So there is a dot. There is a dot in the center. If we get to see this dot, then definitely consider neurocysticercosis. And if there are multiple of them present, that is called as starry sky appearance. Starry sky appearance. A young adult presents with seizures. Contrast MRI shows solitary ring enhancing lesion in the parietal lobe with surrounding edema. Okay. On MR spectroscopy, there is elevated logi. This is the clue. And here you will be able to answer. Elevated lipid peak and reduce NAA. There is no eccentric mural nodule. Which diagnosis is more likely? हाँ जी ये बताइए प्लीज, जिन्होंने एमआर स्पेक्ट्रोस्कोपी पढ़ा है वो तो आंसर दे देंगे जी तुरंत. MR spectroscopy, please. So lipid peaks, they are typically seen. You see here. What is the normal pattern? On MR spectroscopy, what is the normal pattern? Normal pattern is here. Normally NAA values are more than creatinine and these values are more than choline. Fine. Now, you see. So choline is a membrane marker, tumors. Fine. And N-acetyl aspartate is a neuronal marker. So let's say any disease is killing the neurons, any disease in the brain which is killing the neuron, it will cause decline in the value of NAA. N-acetyl aspartate. Any disease which is killing the normal neurons, any disease which is killing the normal neurons will cause decrease in the level of N-acetyl aspartate. Now please, somebody tell me, there is one disease. There is a disease in which NAA values don't decline at all. In which NAA values don't decline at all. कौन सी ऐसी बीमारी है जिसमें NAA values don't decline, rather they keep on increasing? So that is Canavan disease. Canavan disease. Now, coming back, in tuberculosis, lipid peaks are seen. In tuberculosis, lipid peaks are seen. Tuberculosis, lipid peaks are seen. In tumors, in case of tumor, choline peaks are seen. In case of tumors, choline peaks are seen. Case of tumor, choline peaks. In case of tuberculosis, lipid peaks are seen. फाइन. ये दो इंपॉर्टेंट चीजें हैं, ये आपने याद रखना है. तीसरा आपने याद रखना है व्हाट इज द नॉर्मल वैल्यू, आई मीन व्हाट आर द नॉर्मल पोजीशंस. So N-acetyl aspartate values are more than creatinine and creatinine values are more than choline. And of course, you'll have to remember about Canavan disease. There is deficiency of an enzyme. Therefore, NAA values never decline. A child with fever, headache, and cranial nerve palsy undergoes contrast CT brain. So, diagnosis is tubercular meningitis. Fine. Okay. What finding is commonly seen in tubercular meningitis? What finding is commonly seen in tubercular meningitis? Yes, please. So your patient has tubercular meningitis. Remember, जब आप practice में जाओगे, when you will see that tubercular pus, it is very, very thick, very, very heavy. So what will happen here? all the tubercular pus, it will start trickling down. It will start trickling down. All the tubercular pus, because it is very, very heavy, it will start trickling down. It will start trickling down. So you will get to see basal meningeal enhancement. Basal meningeal enhancement. This is what you will get to see, right? Basal meningeal enhancement. What else do you get to see in tuberculosis, tubercular meningitis? You might get to see hydrocephalus. You might get to see. You might get to see infarcts. और क्या दिख सकता है हमें सीटी स्कैन में? यू माइट गेट टू सी टुबरकुलोमास. बट मेन तो आपने यही याद रखना है, पस नीचे की ओर आएगी एंड यू विल गेट टू सी बेसल मेनिंजियल एनहांसमेंट. फाइन. नाउ एम्प्टी सेला, when the pituitary gland is destroyed, and sella turcica, it is filled with CSF. Right? So when the pituitary gland is destroyed, what do we get to see? We get to see empty sella sign. Bat wing sign, it is seen in pulmonary edema on X-ray. It is seen in pulmonary edema on chest X-ray. Ground glass opacity, it is seen on HRCT, high resolution CT scan, in pneumonia. What kind of pneumonia? Viral pneumonia. It is also seen in interstitial lung disease. It is also seen in pulmonary edema. So the other options. Very simple. Laddu question. A male neonate presents with poor urinary stream and bilateral hydronephrosis. MCU shows dilated posterior urethra. So the diagnosis is posterior urethral wall. Exclusive anomaly of the male urethra. Then cricket ball bladder. Now you will get to see, which investigation you will perform? MCU, micturition cystourethropy. Fine. Treatment, fulguration, cystoscopic fulguration. Cause of death, pulmonary hypoplasia, pulmonary complications. They are the frequent cause of death. Okay. Now, it was an easy question, right? A patient presents with acute flank pain radiating to groin. Best investigation for suspected ureteric calculus is non-contrast CT scan. Fine. Now, remember, some of the stones, they are radiolucent. Right? So, what is the mnemonic for those kind of stone? Taxi. Fine. Triamterene. Fine. A is for acid. Which acid? Uric acid. X is for xanthine. I is for indena vir. So you see here, for other contrast CT may be required, but uric acid stone is a different type of stone. This is clearly seen on dual energy. It is clearly seen on dual energy CT scan. Uric acid stones. Most common radiolucent stones, they are typically seen on dual energy CT scan. Okay. A child has large renal mass that displaces vessel rather than encasing them. The mass is most likely. Anyone please try to answer this question. Yes, Dr. Kush Parmar जी, इसका भी आंसर आप दीजिए प्लीज. नहीं तो हमारे ड्यूरामीटर भाई साहब तो देख फट ऐसे आंसर देंगे। 9 renal mass teratoma usually does not arise from kidney. Teratoma does not arise from kidney. कौन है हमारे डॉक्टर साहब जी? डॉक्टर ओके नहीं ओके teratoma does not arise from kidney. teratoma से यार थोड़ा ज्यादा गलत आंसर हो गया। Teratoma, it is arise from sacrococcygeal region. It will arise from ovaries. It may arise from testes. It may arise from retroperitoneum. I mean, retroperitoneum is the last area to arise, right? So you see here, your patient is typically presenting with Wilms tumor. Your patient is typically presenting with Wilms tumor. Wilms tumor, right? So you see here, so Wilms tumor arises from within the kidney and then it starts expanding. There is something special. Let's say this is the midline and let's say this is the kidney. Okay. Now let's say this is the kidney. Suppose on this side Wilms tumor is there. Wilms tumor will start growing outward. Wilms tumor never crosses midline. Wilms tumor never crosses midline. Whereas let's say on the other side, there is neuroblastoma. Now neuroblastoma will cross the midline, It arises from adrenal gland. It will definitely cross the midline. Right? Okay. A child presents with abdominal mass. Two questions and then we will discuss some details. A child presents with abdominal mass. CT shows adrenal mass with calcification encasing major vessel. So you see the answer is neuroblastoma because Wilms cell tumor, it will arise from kidney. Renal cell carcinoma, it will arise from kidney. And hepatoblastoma, it's a benign tumor arising far away. So here the answer is neuroblastoma because that's the only tumor which is arising from adrenal gland, Now see. So here, we have created a table to differentiate both Wilms tumor, to differentiate Wilms tumor from neuroblastoma. So Wilms tumor will take origin from the kidney, whereas neuroblastoma will either arise from the adrenal gland or from sympathetic chain. It will displace, it will encase. Calcification rare, calcification common. Midline crossing never, this is common. Fine, this will common. Now neuroblastoma, it will displace the kidney downward. So that's how you differentiate between Wilms tumor and neuroblastoma. Erect chest X-ray in a patient presenting with acute abdomen. So again, that's a laddu question. Now let's say there is a rupture, there is a perforation. So what will happen? The air will come and air will settle here. Now this is called as pneumoperitoneum and it is seen on the X-ray and then we call it as cupola sign. Pneumoperitoneum, free air, pneumoperitoneum, right? So this could be due to duodenal ulcer rupture. This could be due to ileal ulcer rupture. So this is seen in tuberculosis. This could be seen in tuberculosis. This could be seen in typhoid. Okay, easy one. 70-year-old man presents with abdominal distension, pain, and absolute constipation. X-ray shows massively dilated loop of colon arising from the pelvis with its apex pointing towards the right side. So this is the apex pointing towards the right side. No hostile markings are seen crossing the full width. What is the diagnosis? So you see this one, it is typically coffee bean sign, also known as omega sign, also known as bent inner tube sign, also known as bent inner tube sign. Fine. So your patient is suffering from sigmoid valvulus. Your patient is suffering from sigmoid valvulus. 70 to 80 years is the common age. Anti-clockwise is the rotation, right? Anti-clockwise is the rotation. Symptoms appear gradually. Symptom appears gradually. What is the treatment? Flatus tube. Try derotation with flatus tube. Fine. Now, if there are features of peritonitis, fine, peritonitis, then you will do the surgery. Kidney bean, that's more specifically called as embryo sign. That's more specifically called as embryo sign. Right? Embryo sign. In the cecal valvulus, yes, of course, it is called as embryo sign. Embryo sign. Cecal valvulus, everything will be opposite. Apex will be on the left side. Fine. Next thing is the features will appear immediately. Right? It will rotate in the clockwise. Most common age will be 50 to 60 years. So cecal valvulus and sigmoid valvulus are completely different from each other. A young patient has right iliac fossa pain. Ultrasound shows blind ending non-compressible tubular structure 6 mm in diameter. Again a laddu question. Thank you. See, so this is the blind end. So your patient is suffering from acute appendicitis. Yes, 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 I'll tell you. Dr. Durameterji. See, what happens is in sigmoid valvulus, the contents are solid. Okay. Now, sigmoid valvulus, what happens is when the rotation occurs, contents are solid, they are not more of gases, right? So when the rotation is 180 degree, at that time, the features are more like that of obstruction. Whereas when the rotation becomes 360 degree, at that time vascular compromise occurs. And then, severe pain starts. In cecal valvulus, the rotation, even a small degree of rotation, it will twist the blood vessels along. So that is why cecal valvulus, the pain is because of ischemia. That is why it is sudden. That is why it is severe. Sigmoid valvulus जब तक 360 डिग्री रोटेट नहीं करेगा तब तक उसकी ब्लड सप्लाई बनी रहती है, right? That is why the features are gradual. That is why the features are slow. Okay. Okay. So investigation of choice in acute appendicitis is contrast CT scan. And how do you decide? You decide by Alvarado score. Remember the mnemonic Mentrals. Mentrals is the mnemonic. Mentrals is the mnemonic, right? A 10-month-old infant is brought to emergency with intermittent episode of inconsolable crying. बच्चा या तो रोता है या सोता है. Pallor for last 8 hours. Child becomes lethargic. There is vomiting, but it is not persistently bilious. बीच बीच में रास्ता खुल जाता है. Abdomen is mildly distended and per rectal examination shows mucus mixed with blood. So this is red currant jelly stool. Red currant jelly stool. Ultrasound abdomen shows right-sided mass with hyperechoic central core surrounded by hypoechoic bowel wall. Right? Right-sided. Doppler shows preserved vascularity. What is the most likely diagnosis? Midgut valvulus, it presents at birth. So answer is ileocolic intussusception, ileocolic intussusception. Yes, exactly, Dr. Kush Parmar ji. So ये जो सारी लाइनें हैं ये वाकई वही है. This is basically donut sign only. This is basically donut sign. Donut sign को थोड़ा सा जैसे किताब में लिखा था थोड़ा expand करके लिख दिया, क्वेश्चन थोड़ा डिफिकल्ट बनाने के लिए, right? Now, so you see here, what do we get to see? We get to see ace of spade sign. कैसे? Barium enema पे. Ace of spade sign we get to see on barium enema. We get to see crescent sign on X-ray. We get to see crescent sign on X-ray. Ace of spade is also called as bird of prey sign. Bird of prey sign. Donut sign, it is seen on ultrasound. If we take the transverse view, we'll get to see donut sign. Otherwise, we'll get to see pseudo kidney sign. We'll get to see pseudo kidney sign. Fine, on the longitudinal view. A patient with sudden dyspnea and pleuritic chest pain is suspected to have pulmonary embolism. Imaging modality of choice. So pulmonary embolism, imaging modality is CT pulmonary angiography. CT pulmonary angiography. Pulmonary edema. Yes, Dr. Dhanuji, you're right actually. So at the third attempt, if the edema is not successful, then you'll have to do surgery. So CT pulmonary angiography. Simple question. 16-year-old boy presents with pain and swelling around distal thigh. Pain is worse at night and is not relieved by rest. X-ray shows aggressive mixed lytic sclerotic lesion centered in the metaphysis of distal femur. There is no cortical destruction. There is no cortical destruction. The periosteum is elevated at the margin of lesion and fine radiating spicules of new bone. So this fine radiating spicules, what is this? This is sunburst appearance. Sunburst appearance, fine radiating spicules, sunburst appearance can be seen in any tumor, but commonly seen in osteosarcoma. Commonly seen in osteosarcoma. Here you will get to see onion peel, right? Okay. Giant cell tumor is a benign tumor, and chondrosarcoma, you don't see this pattern. It's the third most common malignant tumor, but you don't get to see this pattern. 68-year-old man presents with persistent back pain. That means something is wrong with the lumbar vertebra. Fatigue and recurrent infection. Laboratory tests show anemia, ESR, hypercalcemia, and kidney dysfunction. Skull radiograph shows sharply marginated lucent lesions without surrounding sclerosis. Bone scan is relatively less impressive. Okay, what is the most likely diagnosis? See, osteoporosis. No such features are seen. No hypercalcemia. So in osteoporosis, calcium levels are normal. Gone. Multiple myeloma. Most common age 50 to 70. Most common site lumbar vertebrae. Fine. Anomaly, calcium level increase. So it fits all the description. It fills all the description. Multiple myeloma is the answer. Paget disease, calcium levels normal. Osteopetrosis, calcium levels normal. Yes. Dhanushji. 48-year-old woman undergoes screening mammography. The report describes clustered pleomorphic microcalcification in a segmental distribution of upper outer quadrant, most common quadrant to harbor cancer. No definite mass is palpable. Which diagnosis should be chronically suspected? Fibroadenoma. If at all it has calcification, it will present with popcorn calcification, which is macrocalcification. Ductal carcinoma in situ, usually there is no mass, but there is definitely calcification. Definitely calcification is seen. And what kind of calcification it is? Micro calcification. Breast abscess, no calcification, rather there will be severe pain and edema. Fat necrosis, fine. So fat necrosis presents with peripheral calcification, also called as eggshell calcification, again which is macro calcification. Okay, so here answer would be B. Answer would be B. 36-year-old woman is evaluated for weight loss, tremors, episodic palpitation, all signs of hyperthyroidism. There is no eye sign. That means it is not grave disease. No palpable lymph node. That means it is not cancer. Her serum TSH is low. Mildly elevated T3 and T4. Ultrasound shows well-defined solitary thyroid nodule. No lymphadenopathy. Radionuclide scan is performed. It shows focal intense pressure uptake. Focal means at one point. So your patient is suffering from toxic adenoma, also called as plumber disease. It will show hot nodule. It will show hot nodule. Hashimotoxicosis, no. First of all, it will be seen in elderly. A different group. Fine. Slightly more elder to this female. Secondly, this will be a very short history. This will be a very short history. Again, there will be tender nodule. Tender, painful nodule. Here they have not mentioned painful nodule. Okay, so we'll go in with B. Toxic. B is हाँ सारे बहुत सारे B हैं. Yes, yes, yes. इसमें भी B है आंसर. 68-year-old man with carcinoma prostate undergoes technetium 99 MDP scan. Okay, the scan shows diffusely increased skeletal uptake. Just a minute. Diffusely increased skeletal uptake with very poor renal visualization. Right? Wait. Okay. Scan shows diffusely increased skeletal uptake with very poor renal visualization. So what happens is this methylene diphosphonate, when we give it with technetium, it is excreted by kidneys. But if there are secondary bone tumors, they will take up all of it. वो सारा ही अपने अंदर ले जाएंगे, किडनी में कुछ जाएगा ही नहीं. Now this is called as super scan. When there are too many metastases, skeletal metastasis, fine. At that time, all the contrast which you give, it will be absorbed in the metastasis and it will not flow in the kidneys. That is called as super scan. Right? Cold scan means no contrast uptake. Flare. It's a short-term phenomenon. Photon deficient is also cold scan, no contrast uptake. Patient with sudden dyspnea undergoes ventilation perfusion. This is a nuclear medicine. Ventilation images are normal, but perfusion images show multiple segmental wedge-shaped infarct. So that means your patient is definitely suffering from pulmonary embolism. Your patient is suffering from pulmonary embolism. Pulmonary embolism, right? Ventilation perfusion defect. 5-year-old child has recurrent lower GI bleed. Technician 99 per technate scan shows focal tracer uptake in the right lower abdomen. That means we are looking for Meckel's diverticulum. We are looking for Meckel diverticulum, which usually presents with bleeding in children, which usually presents with bleeding in children. So what we are doing is we are looking for ectopic gastric mucosa. फिर से भी ये आंसर अगली बार मैं ध्यान रखूंगा जी. फिर से भी ये आंसर यार. Suspected recurrent prostate carcinoma after prostatectomy has rising PSA, but conventional imaging is negative. So specific imaging for prostate cancer is prostate specific membrane antigen PET CT. Prostate specific antigen membrane PET CT. पहले आंसर बी है हाँ. आंसर इज बी. हे भगवान सच में आंसर इज बी. Again, the answer is B. 45-year-old man received iodinated contrast for CCT abdomen. Within 2 minutes, he develops generalized urticaria. So you see, most common side effect of iodinated contrast is anaphylactoid reaction. Anaphylactoid reaction, which can give rise to anaphylactic shock. And what is the treatment? Yes, exactly. And you will give a subcutaneous or IV. You will prefer subcutaneous route first, then you will shift to IV. 70-year-old diabetic patient with chronic kidney disease is planned for, all the iodinated contrast, they are nephrotoxic. So to reduce, what will we do? Adequate IV hydration with isotonic saline. This is considered best step. This is considered best step. Otherwise, what we can use is N-acetyl cysteine. But what is the best step is to properly hydrate, your patient with saline. So C is the answer here. 58-year-old patient with type 2 diabetes on metformin is scheduled for contrast CT. His renal function is significantly impaired. Fine. What is the main concern if metformin is continued in the setting? So metformin, when metformin remains in the body for long time, it will cause lactic acidosis. It will cause lactic acidosis. Metformin is strongly associated with lactic acidosis, right? Contrast agent dissociates in solution into charged particles, ionic. Compared with non-ionic agent of similar iodine concentration, it will generally have which property? So ionic contrast, for example, let's say ionic area like this. Two particles, more particles means more osmolality. More particle means more osmolality. More particle means more osmolality. No. More particle means more ionic means more particles. Non-ionic means single particle. Single particle. So less particles, less osmolality. More particle, more osmolality. So B would be the answer. 58-year-old man in ICU is hypotensive and mechanically ventilated. Ultrasound is planned to assess, inferior vena cava diameter, cardiac view, right upper quadrant free fluid, and lung sliding. The machine has only three probes: high frequency linear, low frequency curvilinear, and phased array probes. Resident wants one probe that can reasonably perform most of deep emergency views. Superficial, that is linear probe with a high frequency. So high frequency linear probe is not to be used because we want to see deep. Low frequency curvilinear probe, because now low frequency probe, what is the problem with low frequency probe? It has got very poor resolution, and we want to see the heart also. That is why what is preferred: phased array probe. Phased array probe. Fine. This, curvilinear probe is for abdomen, for heart, for lungs. We prefer this phased array probe because this is very, very small. This has got very small footprint. So we can see between the ribs also. Fine. So not taking too much of your time very close to the examination. I'm done with all the questions of ortho and radio both. So nearly like 1 hour for 5-10 minutes for each. Right. Now, if there is any query, please feel free to answer those queries. I'm here for you. I'll try to answer them as soon as possible. I mean, here only, of course, here only. And that brings us to the end of these questions. And that brings us to the end of radiology discussion. Always, always for you, Bhaiji, har samay. Thank you, sir. Thank you. Right. So, Dr. Durameterji, I might not be the right person. नॉर्मल प्रेशर ऑनेस्टली मैंने नहीं पढ़ा. मैं ऐसे झूठ बोलूं आपको, नॉर्मल प्रेशर हाइड्रोसेफलस मैंने नहीं पढ़ा अभी. राइट, बट I'll try and I'll share the notes with you in the telegram group. जैसे 22 तारीख को टेलीग्राम खुलेगा, so डॉक्टर ड्यूरामेटर भाई साहब, मैं इसके इजी नोट्स बना के आपको भेजूंगा. नॉर्मल प्रेशर हाइड्रोसेफलस. थैंक यू जी. थैंक यू डॉक्टर रितेश जी. Right, so maybe we can end the session as of now. Okay. Right. ओके, सो विश यू ऑल द बेस्ट. शानदार से नंबर लीजिए, फटाफट से पास हो जाइए, और फिर पार्टी करने के लिए यही आना है. गूगल पिन में डाल दूंगा. राइट, ऑल द बेस्ट. बाय बाय.